what is the volume status of this patient? That is a very complicated question where actually ultrasound can help you to answer this question very often. Fortunately, we can use several loops, videos, images, and imaging modalities. Here, for example, ultrasound of the jugular vein, TE studies, TTE studies, Doppler studies, and many, many more to figure out what actually volume status of our patient is. Starting with the volume management with ultrasound, it's crucial to understand, it's always to differentiate, is this patient really dry as the desert? Is this patient wet like a watered poodle? Or is it about the heart, the lungs, and many more things, and not always that easy? Overall, patients with severe hypervolemia or hypovolemia always find the way to an emergency department and further on to intensive care treatment. Initially, I want to discuss B-lines. So B-lines are reverberation artifacts. They always originate from a smooth plural line. They are echogenic, so hyperechoic. They do not fade until the end of the screen, depending on where you still see B-mode imaging. They always move with lung sliding. They do not fade. They cover other artifacts such as A-lines, and they are a sign of free lung water. I want to emphasize it really has to be a smooth plural line to call the artifacts B-lines. The first patient we are discussing is George. George presents to the emergency department with severe dyspnea. It was overall relatively quickly progressive at home. He is in the ER. He moves to the intermediate care unit where I see the patient first, and initially the patient has severe dysentachypnea. The suspected diagnosis from the emergency department is pneumonia, and there he got 500 milliliters of a crystalloid. His oxygen saturation, even with oxygen, is really bad, approximately 70 to 80%. And the recommendation from the emergency department is this patient most likely needs to be intubated. Well, let's take a look and figure out, is this patient really dry, and is the dyspnea because of his pneumonia, the initial diagnosis we reported, or is he really congested? Let's take a look at the lungs. And when we look at the lungs, so this is the right side, this is the left side. Here the R is simply wrong, so you can also, depending on your machine, write the various zones you're scanning. And in this case, you have your rib shadows, and in between the rib spaces, there's the smooth plural line. You have plenty of artifacts, so many B-lines. That's a so-called white lung. On the left side, you see a similar image, a lot of B-lines. So does this patient have enough volume, or do we even need more volume to save this patient's life even? Well, of course, when you see a lot of B-lines, this is congestion. This is actually a case of pulmonary edema, so massive B-lines. Everywhere you have the smooth plural line, the reverberation artifacts on both sides, left and right, is very indicative that this patient has a problem with congestion. Moving on to echocardiography. So when you are scanning the lungs, you always should scan the heart, at least to a certain degree, to figure out, is the severe left or right ventricular dysfunction present? Are there wall motion abnormalities, as in this case? Is there a truly reduced ejection fraction or truly reduced ventricular function present? In this case, yes, ejection fraction was severely reduced, around 30%. And George, in combination with those two, we did see the problem with the left ventricle, and we did see a lot of B-lines. And we also did talk to the patient, of course, and he had no signs of infection. He said, I just felt severe dyspnea and tachypnea. I never had a diagnosis of a heart disease before. I have hypertension. He has also diabetes. He didn't say that he ever complained of severe chest pain, but most importantly also his blood pressure was very high when we had invasive measurement. So no more water for George, this is pulmonary edema. And it's very nice with therapy, so with diuretics, nitroglycerin and CPAP, so non-invasive ventilation. Very quickly you do see that this is the plural line. There are still some artifacts present, but you see other artifacts as well, so-called A-lines, the mirror artifacts of the pleural line, indicating that there is less free lung water present. The same is on the left side, you see it over here, and you see A lines and definitely less B lines. And also our patient was feeling much better just briefly after we initiated therapy. So comparing before and after, so this is before treatment, this is after treatment. Here you have plenty of B lines, here you have singular B lines. So this is a case of pulmonary edema due to the high blood pressure and due to the reduction in left ventricular function. So what about George? George definitely doesn't need more volume. We have a new onset of heart failure with reduced ejection fraction with wall motion abnormalities indicating coronary artery disease. We have massive B lines which are improving with therapy. We have a dyspneic patient who again feels very, very quickly way better after initiation of therapy, and a hypertensive patient. Also that of course was treated, so a hypertension-induced pulmonary edema, and this initial diagnosis of heart failure with reduced ejection fraction on the intermediate care unit. Of course, George has to find his way to a specialized cardiological workup, but in the initial state, in the critical state, George needed a quick diagnosis because this was a potentially life-threatening pathology. Going to another patient, it's Victor. Victor is 79 years old and he's a farmer. Now we are scanning Victor. We have several views at hand, and you can go back to the compact echo course to see how all those views are acquired. And in this case, we see something different. We do see here the liver. This is now a visualization from a subcostal approach of the IVC. The IVC is collapsing. You can see it in B mode imaging. You can also see it with M mode. I prefer personally the B mode imaging, as you can really see it way better. But it was not even that easy to keep the IVC in our field of view, but when you take a look at the internal jugular vein, you see that it's also collapsing. And here this is a placement of a needle for a central venous access. You also do see the collapsing internal jugular vein. So what's the problem of this patient? Is he really dry, or is congestion the problem? Well, this is a case of severe hypovolemia. He was a farmer, and dialect, I'm normally speaking, it's Corinthian dialect, it's called Heigen, so it's harvesting hay. It was summer, he had a cold, he was wearing then a jacket, he went home, and he actually fell asleep below the sun. He was admitted with hypothermia. We measured 42 degrees of Celsius, which equals 108 degrees Fahrenheit, so severe hypovolemia due to hypothermia. How can we differentiate? To wrap it up for now, the IVC gives important clues, especially if it's collapsing entirely, if it's really small, if it's collapsing entirely. Plus, in the previous case we had a history, we have a clear answer. This is most likely not hypervolemia, but if it's collapsing entirely, if it's very, very small, it's hypovolemia. Depending on the IVC diameter, if it is above or below 21 millimeters, or equaling 21 millimeters, and the collapsibility, we assume right atrial pressures. So if it is normal, collapsible, and the diameter is not exceeding 20 millimeters, the right atrial pressure will be in between 3 to 5 millimeters of mercury, be mostly say then 3 millimeters of mercury. If the diameter is above 21 millimeters and below 50%, then right atrial pressure is in the range of 10 to 20 millimeters of mercury. Everything in between you can count as 8 millimeters of mercury, and actually there is no reliable upper border. So in case of a dilated, non-collapsible inferior vena cava, we are just roughly estimating the pressures, and that leads to the next very important point. So this cutoff of 21 millimeters and the collapsibility, and if it's not a really clear case of, for example, hypovolemia, it has plenty of limitations. What you can use is a transverse approach. So not only the longitudinal approach of the IVC, but also a transverse approach. If you see a round IVC with no collapsibility, it also points towards hypervolemia or elevation of right atrial filling pressures. If it is oval and nicely collapsible, it points to euvolemia. But again, this is not the only vessel or the only view we need. We need more information. We of course need the clinical findings. This is utterly important. And we can take a look at jugular veins. We can take a look at the heart. So we can get and gather a lot of additional information. In echocardiography, as we have seen before, we have a reduced ejection fraction plus with lung ultrasound massive B lines that also leads to a clear answer. There are some pitfalls, for example, in a patient with ARDS. So if you have skipped areas, for example, so you should scan more areas of the lung, that can be a pitfall. So also keep in mind that there are distinct differential diagnoses in evaluation of the heart and the lungs. Continuing to more measurements to figure out if there is hyper or hypovolemia present, we have two patients. They actually complain of dyspnea, and here we have two signals. That's the pulse wave Doppler signal across the mitral valve, so the inflow into the left ventricle. And those two signals, they are entirely different. If you want to know more about diastolic dysfunction, go to the designated video. In this case, we are just looking at this signal for now, because here we have a very, very large E and a small A wave, and here we have a small E and a large A wave. So the E wave is the suction of the ventricle, the A wave is atrial contraction. So in this case, it's very steep and high, and in this case, it's very, very low. The first one is Daniela. Daniela is 52 years old. She had a huge anterior myocardial infarction, severely reduced ejection fraction with 15 to 20%, and she truly feels bad. Dyspnea, presenting with dyspnea with this signal. Ulrich, on the other hand, he is 68. He had diarrhea, hypertension, diabetes. He likes to drink beer, and he also presented confused and stated being dyspneic. Daniela, does she need volume? Well, clearly no. This is a so-called restrictive filling pattern. E to A exceeds 2. This is actually 2.6. And in terms of diastolic dysfunction, this is diastolic dysfunction grade 3. What is more important, this is a case of restrictive filling, which equals always elevated filling pressures. You can see that also the heart has to be damaged. So in a young, healthy individual, a very sporting individual, an athlete, so you can even find E to A ratios above 2, above 3. But in a case of severely reduced left ventricular function, in a case where the patient is beginning to decompensate, we see the dilated IVC here. Even with contrast imaging, you see a dilatation of the IVC with a reduction in collapsibility. Also, lung ultrasound did show some B lines where you can assume that there's pulmonary congestion present. There were also small pleural effusions. So overall, this is a fitting image for a patient who definitely does not need volume. On the ICU, for example, if you see this restrictive filling pattern, always be careful with volume administration. It not always necessarily means that the patients are endlessly hypervolemic, but in case of restriction with volume, you should be very, very careful. Another information with her echocardiographic exam is that the E to E prime ratio, again let me refer you to the video of diastolic dysfunction, is elevated. So before the acute decompensation, it was in the range of 15 mean measurements, so medial and lateral. In this decompensated state, it was elevated to 22. So we have many indicators that there truly is hypervolemia present. And of course, this patient therefore is congested and needs diuretic therapy. Ulrich, on the other hand, he is hypovolemic. Just take a look at this signal. So this very small E wave means that the ventricle, the suction of the ventricle is very, very weak. So the large A wave means that there's hypovolemia present. So this very small E wave compared to the very large A wave can hint towards hypovolemia. Also in younger patients, this is not a normal Doppler signal. So all the time in younger individuals, 40, 50 years of age, if you have a smaller E compared to the A wave, you always should ask, did you drink enough? What points towards the hypovolemia of this patient is also the blood flow. It's everywhere showing turbulent flow, and the ventricle, the walls are there, they are thickened, but still you can see that the entire ventricle is almost obliterated. So really there is little volume present in the ventricle. It shows a hyperdynamic ejection fraction and pointing towards, with this small E and this tall A wave, towards hypovolemia. This patient needs fluids. Furthermore, you can measure gradients. So when you use the continuous wave Doppler across the aortic valve, you get several signals and several measurements you can perform. The peak gradient here is very high, around 90 millimeters of mercury, but there's always the question, is this an LVOT gradient or is this a midventricular gradient? And to summarize, Ulrich suffers from hypovolemia because of his previously discussed conditions. Continuing our exam, you see that the IVC is also collapsing entirely, and we even performed a TE study. So on the one hand, he also had infection, but we also wanted to make sure that there is no real LVOT obstruction present. And you can see that here is the mitral valve, the aortic valve to a certain degree. It looks calcified, and this is the interventricular septum. And the SAM phenomenon is a systolic anterior motion of the mitral valve, where the anterior leaflet of the mitral valve is pushed towards the interventricular septum, creating an LVOT obstruction, a dynamic obstruction, and on the other hand, mitral regurgitation in this patient who clearly has no signs of hypertrophic cardiomyopathy, but still a thickened left ventricle. In this case, there is no real SAM present. There is probably some turbulent flow here. There's a caudal SAM, so the chordae tendinae are a little bit pulled into the left ventricular outflow tract, but overall it doesn't point towards severe SAM. So what we have seen before, this very dagger-shaped steep curve at the end, this points towards midventricular obstruction, which you can also see even though the image quality for the ventricles is reduced in the TE study in this loop. So remember, E to A ratio above 2 equals restriction, restrictive filling patterns with elevated left ventricular and left atrial pressures. Be aware, of course, as I mentioned before, this could also be a normal finding in athletes. Again, you can take a look at your patient, you can perform additional views to figure out if it's truly a hint towards hypervolemia or if it is simply a very young, very athletic person sitting in front of you. The small E wave, the large A wave, shows that there is most likely volume needed also in the intensive care unit setting, also in intubated patients. The E to E prime above 14, a mean value of the septal and the lateral measurement of E to E prime with tissue Doppler shows elevated filling pressures, and it also shows a trend. So if it's rising, pressures are also more and more elevated. Additionally, you can look at left ventricular ejection fraction. Is it reduced, as we have seen in the patient with coronary artery disease with the huge infarction before, or is it hyperdynamic? The IVC, is it collapsed or dilated? Does it fit the other findings? Is there systolic anterior motion of the mitral valve, which has to lead a very careful use of catecholamines and volume support for this patient, because catecholamines can even worsen the SAM and the LVOT gradient, and you can use the continuous wave Doppler to visualize it and the pulse wave Doppler for guidance to see where actually the problem is originating. Is it from the LVOT, truly from the LVOT, or is it interventricularly, or is it even in the apical regions? And one thing I want to discuss, in our emergency setting, we very often use ultrasound with also ECG, but as you can see, we not always use it, but I would still recommend all the time you're scanning a patient. And when you think about placing an ECG, and you have to remember doing it. Now we play a gradient game. We have this patient, George. He's now 83 years old. He has an elevation of his TAVI gradient, so he received a valve. He had aortic stenosis. He's truly, you can see, really bad image quality. He's hard to scan. He has atrial fibrillation, ventricular extrasystole, and we see also to a certain degree already that there is LVH present after aortic stenosis. And now we want to know, is there a relevant gradient of his TAVI or TAVR, transaortic valvular replacement, or is it another gradient or another problem? We focus on the 5-chamber view. You see the ventricle a bit better. You see here the TAVR. There is certainly most likely a hyperdynamic left ventricular function present, but be aware there's also ventricular extrasystole. And when you use color Doppler, you also see a lot of turbulent flow. So now we have to figure out, where is the gradient? Is the gradient simply the aortic valve? Is it a problem with the TAVR? Well, with this continuous wave Doppler signal, you do see that there are also not only one, but several signals in this one measurement. So we have to really be careful to what we measure and how we define and differentiate those signals, there are actually two peaks. You have this first peak and this second peak. So the first one, that belongs to the TAVR. It's overall in the mean measurement below 4 meters per second, so most likely it's not a relevant stenosis. But the second signal, that's still unclear. This is more this dagger-shaped signal. Here you can see it again. And this points towards an obstruction, interventricular or LVOT obstruction. And when you even optimize the image, you see here again the TAVR gradient and here this second flow. How can you solve this? How can you find where the gradient actually is? Well, you use the pulsed wave Doppler. You put the pulsed wave Doppler first in the aortic valve, then track it towards the LVOT. And in the LVOT, we have this normal LVOT signal. It only needs one signal to be sure this is not significantly above 1 meter per second. So here is not a relevant gradient. You go more apical and you see that here still is no relevant gradient. But when you go even a little bit more inside the ventricle, so the mid-ventricular area over here, you see suddenly there is this steep curve, this dagger-shaped signal. So this is a case of mid-ventricular obstruction. And it becomes even clearer when you use contrast imaging. So there's a little bit of a bundle branch block, so the heart is not contracting entirely normal. So not all walls of the heart are contracting at the same time. So you see a little bit of this rocking motion. You see here again the continuous wave Doppler where you see this gradient again. And in this two-chamber view, you even see clearer this mid-ventricular obstruction due to hypovolemia. It was summer, the patient did not drink a lot of water, so a case of hypovolemia. And the gradient is in the area of the mid-ventricle, so not in the LVOT. Here we have the second gradient game. We are discussing now a patient with Takotsubo cardiomyopathy. You see this large apical ballooning, severely reduced function, but this hyperdynamic basal segments which you can see in this Takotsubo cardiomyopathy. And you have, of course, the diagnosis of a HFrEF, so there are relevant wall motion abnormalities, large areas, so the function overall is reduced. The basal segments, they have to cover, so to speak, for the akinetic segment, so they are hyperdynamic, and you see that there is also most likely LVOT obstruction. Now we're interested about the gradients. This patient was also on our intensive care unit. And when we place a continuous wave Doppler, we do see a gradient in the LVOT. And now you again have two signals you have to differentiate. You have here the first, that will be the aortic valve, but then there's this second signal. It's also dagger-shaped, but it's not that steep at the end. So this points that this is a signal truly in the LVOT. Of course, you can use pulsed wave Doppler to see that there is no obstruction in the apex, but that is rather obvious as there are large wall motion abnormalities over here. So this is truly a LVOT obstruction. You can see it with color Doppler that there are two areas where there's turbulent flow. First of all, of course, in the LVOT, you see it over here, and also this area where there's mitral regurgitation present. So because of the SAM, the LVOT obstruction, the anterior mitral valve leaflet is pulled more and more towards the interventricular septum and thus creating mitral regurgitation. The more SAM, the more MR, and this is a vicious circle if you use catecholamines, which will even make the LVOT obstruction worse and the patient will deteriorate and eventually even die. So what do you need to do? Well, the IVC in this case also did fit to a more hypovolemic state. It was collapsing. There were no B lines. And of course, with this large akinetic areas, with this severely reduced left ventricular function, you have to be very careful with volume administration. A personal tip from my point of view, scan the lungs. If you see more and more B lines, this patient has way more than enough fluid therapy, and this patient then is starting to have pulmonary congestion and eventually pulmonary edema. If you do not see any B lines, more volume administration will be possible. Furthermore, you can of course evaluate the gradient from time to time to see if it's more severe or if there's less gradient and also less MR present. Here I have this measurement of another gradient. So this is not an aortic valve or an LVOT gradient. You always have to be careful when you measure here. You see that there is not the aortic valve you primarily measure, but this is the measurement of mitral regurgitation. So always keep in mind where you measure and which gradient fits the actual structures you are measuring and visualizing. In this case, we have a patient with a mitral valve prolapse with an MR in late systole. There is a normal opening of the valve, there is clearly no SAM, but when you measure the continuous wave Doppler signal, you have here the aortic valve signal and here another very steep, very nicely to visualize signal. It's around 4 meters per second, 3.5, 4 meters per second. But if I take a close look, this is due to the eccentric jet of mitral regurgitation. So what you're actually measuring is first the aortic valve signal and then a little bit of the MR. So this is an eccentric MR and this is a pitfall when you measure certain gradients. So what do we know so far? I want to emphasize again, E to A above 2 shows restriction. Be very careful with volume. The small E wave, the very large tall A wave shows you most likely there is more volume needed. Of course, the IVC, the lung ultrasound has to be concordant. The LVOT obstruction shows you that this patient will need more likely volume and you have to be really careful with catecholamines to not worsen the LVOT obstruction. And furthermore, you can check the left ventricle. The left ventricle, if it is small and hyperdynamic, this is the patient we have discussed before with the TAVR. If it is small and hyperdynamic, of course, in the clinical context again, with this kissing papillary muscles, so here the papillary muscles, the posterior medial, the anterolateral, and they are kissing each other, which means that there's hyperdynamic left ventricular function present, which again then could mean that there is volume needed. If the overall area is below 10 square centimeters, this patient most likely need volume. Of course, there are many pitfalls: left ventricular hypertrophy and hypertrophic cardiomyopathy, amyloid heart disease, also HFpEF heart failure with preserved ejection fraction by means of, for example, hypertensive heart disease. So we have to be very careful and see it in a clinical context. Furthermore, the pitfalls include, we said, amyloid heart disease, hypertension, but also if you use inotropic therapy, vasodilators, they can lead to hyperdynamic left ventricular function. The image quality is essentially, of course, all Doppler and B-mode measurements, but also the angle dependency needs to be addressed when you talk about Doppler measurements. In this case, here you see the first signal that was still in the aortic valve. Here you have the true LVOT signal, and here you have a different signal more towards inside the left ventricle. So also always question yourself, is the signal I'm measuring truly the signal I want to measure? What else do we have also in ventilated patients? Well, is the IVC when the patient has ventilation, ventilatory support below 12 millimeters, it's with a very high likelihood that the right atrial pressures are below 10 millimeters of mercury. If the IVC with ventilation, so with respiratory support, has a relevant collapsibility there, you can calculate an index. If this index is above 18%, the fluid responsiveness is most likely. You can also simply check the IVC and see if it is approximately 20% collapsible in an intubated and ventilated patient. Of course, the PEEP shouldn't be too high, but if you see a certain degree of collapsibility, that would point towards a need for volume. A fun fact, the SVC, you can use the same formula, so the collapsibility index, you can scan it in TTE and TE with a cutoff of 36%, not 18%, so the SVC is normally more collapsible than even the IVC. If the IVC is huge and there is no collapsibility at all, I would be very restrictive with volume. Furthermore, you can use the pulsed wave Doppler signal. We have discussed it now several times. If there's a variation with the respiratory movement and the respiration of the patient, you see that and look at more signals over time. With also the respiration, you can even use a respiratory curve. And if you see a variation of above 15%, that most likely points towards fluid responsiveness. In a breathing cycle, if it is below 10%, there will most likely be no relevant fluid responsiveness. The stroke volume or VTI or even the maximal velocity, you can use a passive leg raising or a volume stress test. You can, for example, administer 250, 500 milliliters of crystallite. This is a fluid challenge. And if the stroke volume or the VTI, you can also use simply a visual assessment like with the IVC and not per se calculate many indices. If you do that and you see with this passive leg raising or the volume administration that there is an increase of VTI or the stroke volume of more than 10 to 15%, there's also most likely that a fluid responsiveness is in this patient given. Of course, you have to have an optimal LVOT signal with pulse wave Doppler. You have to measure the signal before and immediately, and I would also recommend during a fluid challenge, during the passive leg raise test. What it is about, so that we are also discussing some more formulas, so just something you can, for example, print out or take a photograph of, so that you simply have it written down. Overall, the main question or the main goal is optimized organ perfusion, arterial and venous. So in the arterial system and the venous system, the oxygen, of course, needs to be transported. You need enough blood to transport O2, and you need to have an adequate cardiac output, so no forward failure to have it transported. The cardiac output is the stroke volume times the heart rate. The stroke volume, again, is then end diastolic volume minus end systolic volume, or you can calculate it with the VTI of the pulse wave Doppler signal in the LVOT and the cross-sectional area of the LVOT. You see here this measurement. This is the cross-sectional area you can measure in the peristernal long axis view. Here's the calcified aortic valve. So here you would place the measurement a little bit over measuring in this area optimizes the measurement. But if you want to know more about the aortic stenosis and how you perform these measurements, take a look at the videos where the aortic valve and the aortic stenosis is discussed. This measurement, it's always dependent on the stiffness of the left ventricle. Again, diastology and diastolic dysfunction, filling pressures, they're very important. But you can dedicate hours and hours of lectures only to this topic of diastolic dysfunction. The stiffness also induces the systolic wall stress, and even if you put more fluids into the patient to achieve more stroke volume, to achieve more venous return, at some point it's simply too much. You cannot fill up a balloon which is already full. The stroke volume to measure needs the LVOT diameter, which is not always easy to measure. The pulse wave Doppler needs to be in the LVOT, and you have to have an optimal signal tracing and even more optimal the body surface area to calculate the stroke volume. Here you have some measurements where you can see the maximum velocity across the LVOT and a calculated aortic valve area which shows aortic stenosis not below 1 square centimeter, so not severe aortic stenosis, of course, a stroke volume indexed with 73 milliliters per square meters and an overall stroke volume of 142 milliliters. Furthermore, it is about having a blood pressure which is normal and enough for organ perfusion. So the mean arterial pressure you can measure with cardiac output times the systemic vascular resistance. The systemic vascular resistance, on the other hand, is the venous blood pool, and we will talk about the venous congestion in a bit. And you can also even use ventilation. Ventilation, of course, changes pressures, and you can use this end expiratory occlusion maneuver. So you switch off the respirator for 15 seconds, of course, first pre-oxygenate the patient optimally. If you perform that, you have more venous return. With ventilation, you have reduction. Then you have an intrinsic volume challenge, so that you can also try and see the stroke volume. You can see the signal if there's improvement of 10 to 15% over time with this intrinsic volume challenge. There will be fluid responsiveness present. Continuing with the LVOT and the VTI, always place the Doppler initially in the aortic valve. You will see a signal which is not displayed very well, but when you move it slowly backwards, the sample volume slowly backwards until you reach the LVOT, you will truly be in the area where you actually measured the LVOT diameter. And here you have the LVOT signal, whereas here you are still in the area of the aortic valve. The VTI, on the other hand, should be around 20 centimeters for the RV outflow and the left ventricular outflow. So the VTI of the left ventricle, the LVOT signal, and the VTI of the RVOT signal. 20 centimeters is in the range of normal. The maximum velocity should be around 1 meter per second. Of course, a visual interpretation of the signal in the acute setting also helps, so still you should be used to those measurements. So simply repeat and measure that you also feel more comfortable with the visual assessment as well. The SVC, we talked about it briefly. The SVC is a continuation of the IVC from a subcostal approach. You can scan it. This is the IVC, so the marker points towards the head, towards cranial, and the continuation with a little bit of sometimes tilting and rotation. You can see another vessel entering the right atrium, which is then the SVC. Here you can see a color Doppler across the SVC, and you see a nice collapsibility in this young and definitely not decompensated patient of the IVC and also the SVC only during this normal scan performed over here. In this case, we have a patient with a recompensated heart failure, where you see again here the SVC. You have to be in the right timing. Here's the SVC. Still there is less collapsibility compared to what we have seen before. Here we have the congestion of the IVC and the congestion. In the last glance, you see the SVC. There is no collapsibility. It definitely looks larger, and optimally you can visualize it in a bicaval view in a TE study. So this is a TE study, a transesophageal echocardiography. So if a patient is already on the ICU and you perform a TE study, don't forget to look at the bicaval view to visualize the SVC seen over here. Here you have another structure, the Eustachian valve, and here you even see parts of the right atrial appendage. This is the interatrial septum, which is hypermobile. So primum septum, secundum septum. The next topic we are discussing is the VExUS, the venous access ultrasound grading system. As mentioned before, initially it was all about cardiac output, the arterial system, but you can also measure and quantify congestion in the venous system. So there are 4 steps needed. First of all, you take a look at the IVC. It is published that in the longitudinal plane, if the IVC is above or 20 millimeters, you have to continue and look if there's congestion present. If it is below 20 millimeters, then there's a grade 0, there's no congestion present. Still, even though it's collapsible or not collapsible or enlarged or not enlarged, always look at the form and look at the transverse plane and the collapsibility. So this is very important when you perform a VExUS exam, to make up your mind and do not make mistakes initially at already the first step while evaluating the blood pool. The next step is to look at the hepatic veins. I personally like this measurement, maybe due to the close proximity of the hepatic veins and the IVC to the right atrium, maybe because this measurement is also performed in case of constrictive pericarditis, but sometimes, and some of my colleagues consider this a little bit more tricky or difficult. If you want to measure it, of course, use the optimal aligned vessel in this transverse plane to the star of the liver veins. You can see the left hepatic vein, which is the most optimal to measure, and you have here a signal, an S and a D wave, and this is definitely a congested patient. If you cannot see it immediately, doesn't matter which one, it has to be one of the hepatic veins. Go to the right upper quadrant and simply scan through the liver and try to find an optimal view towards the hepatic veins and measure them more proximal. So not in the very end where you simply see a little bit, but really closer to the inferior vena cava. It is also overall better to use an abdominal transducer because simply the measurements, the color Doppler, they are optimized for abdominal imaging compared to the echo transducer. Still, you can use the echo transducer as well. How to grade it? Well, here's the grading system which is recommended and we also use. We have the hepatic vein signal, the portal venous signal, and the infrarenal signal. And normal is this S wave and this D wave with the hepatic vein. If the D wave is then larger than the S wave, it's abnormal, but only mildly. And as we have seen before, if there's an S and a D wave, it is severely abnormal. This also is the case when there is, for example, a severe or even massive or torrential tricuspid regurgitation present. The portal venous system should have a pulsatility below 30%. If it is more pulsatile, it points towards mild congestion. If it is very pulsatile, so above 50%, it is severe congestion or a sign for severe congestion. Overall, use more, not only one, for example, the hepatic vein or the portal vein or the renal signal, but use more and also the clinical information, echocardiographic evaluation, and of course the IVC to really be sure that you are grading it optimally. The infrarenal signal, you have, because they are very, very small structures, an arterial flow most likely and this continuous venous flow. If you have two waves, that points towards mild congestion, and if you only have the D wave, it points to severe congestion. And then you have grading, you have a grade 0, there is no congestion present. Look at the IVC, also look at B lines, look at the heart, look at diastolic dysfunction, look at collapsibility of the IVC, not only the size, look at the form. Is it oval, which points towards a normal IVC? Is it really round? That points towards a dilated or congested IVC. Grade 1 means mild congestion, you have a pathological IVC and any combination of normal or mildly abnormal waveforms. So we are here now in this range. If you have at least one severely abnormal pattern and the IVC is a moderate congestion, and if you have two or more severely abnormal waveforms, it is a grade 3 in the VExUS grading system, which is severe congestion. To see the hepatic veins and the hepatic venous signal, here are some examples. Use color Doppler for guidance because of course the venous signal, it should be blue in color Doppler, so blue is away from the transducer, red is towards the transducer, and when you use pulsed wave Doppler, it also should be on the lower end, so the negative side, because it's away from the transducer. Here you have this example with a suboptimal signal. When you have the optimal signal, you see nicely the S wave and the D wave, the S wave and the D wave. Here's another example of a non-congested person. If you're not sure, look at the ECG and the signal. So also for that reason, it's sometimes very helpful to have an ECG. If it is normal, the S is larger than the D wave, which is the case in both examples. And if there is congestion, mild congestion, there is a reversal, so the S wave would be smaller than the D wave, and the reversal we have seen before. This, again, can be very difficult. I personally like this measurement. More to the flow pattern, the ECG during the exam helps because the A wave should follow the P wave. The A wave is this small positive wave seen over here. Here we have the P wave and here we have the A wave. So this is also a normal sign. The S wave then follows the R wave. So we have here the QRS complex and we have the S wave after the R wave. The D wave follows then the T wave, which is also the case here, seeing the D wave and the S wave. And there's also a V wave, which is in between the S and the D wave. So a small retrograde wave, the right atrial contraction, is the A wave that is normal. Two small antegrade waves due to the systole, the S wave, and the diastole, the D wave, should be present, as we have seen here in the signal and the signals before. The small retrograde wave during systole and diastole, which can be seen as the tricuspid valve returning to the normal position. This is a very small volume shift and just causes a little bit a rise in pressure, still physiological, which is this V wave. So this is the closing of the tricuspid valve. So systole, diastole, closing of tricuspid valve, and the small retrograde A wave, the atrial contraction. Pathologically is if the D wave is larger than the S wave, showing elevated right atrial pressures or hypervolemia, and severely elevated right atrial pressures lead to a positivity of this S wave. So the S wave will be positive. There are several pitfalls. The significant TR leads to a declining of the S wave, and then the S wave is smaller than the D wave, and even to a positive S wave, it's possible. This is tricky, even possible without systemic congestion at all. So you should have more measurements and more signals, not just the one. The hepatic venous flow in case of liver cirrhosis, steatosis, hepatic lymphoma, abdominal cartridge syndrome, stenosis of the IVC during Valsalva maneuver also is a pitfall. In case of atrial fibrillation, we have a loss, of course, of the A wave and a reduction of the S wave without systemic congestion. So the optimal signal, the optimal interpretation of the measurements and knowing the heart, also knowing comorbidities of the patient, liver comorbidities, is very important to perform a correct VExUS exam. There are more pitfalls, for example, extrasystole is seen. In this case, is a ventricular extrasystole, constrictive pericarditis with septal shift and septal pounce. The ventricular interdependence changes the signal. this is then the topic for a specific lecture on constrictive pericarditis. Furthermore, there's no differentiation between hypervolemia and elevated pressures by means of pulmonary arterial hypertension possible. So in case of hemodynamics, the S to T reversal as seen in the previous case denotes a volume overload. Here you also see a smaller S wave, a little bit larger D wave, and here the prominent A wave, a very prominent A wave, also points to elevation of filling pressures and towards hypervolemia, which was present in this patient. So we go back to the initial evaluation. We have this dilated IVC, the dilated hepatic veins, and this is a grade 3 congestion. Very often for this signal, you need really a relevant tricuspid regurgitation as well, but keep in mind this is now pointing towards, and this fits also the B-mode imaging we see, to a relevant congestion. The next is the portal venous signal. The portal vein, you can see over here, the signal should be positive, so red in the color Doppler imaging. If you cannot always get the red signal and you see it in a different angulation, it also can be that this is a negative signal, but keep in mind optimally also for purposes of comparison, you always should measure it same. In this case, you can measure it from a subcostal view, from a CPC view, mid-axillary, for example, with, of course, color Doppler signal guidance, the red signal. In this case, there is a definitely pulsatility present, so there is congestion present. Here you have an example then of the next step, the kidney vein. It is often truly difficult. You need color Doppler guidance. Again, look at the color Doppler, the red and blue color, the red for the arterial part you see over here and the blue for the venous signal. And below is venous, on top or above is the arterial measurement, and you should measure in the interlobar vessels, the right or the left flank, it doesn't matter, but you should be a little bit inside the kidney parenchyma. To see some signals, that is congestion. So here we have this pulsatility of the portal vein, here we have more pulsatility, and here we have severe pulsation in a severely congested patient. Normally the kidney vein should be a continuous flow, but if you have this S and this D pattern, that points towards congestion. Mostly I perform a longitudinal plane with pulsed wave Doppler, here mild congestion, and here I have only this arterial signal and this singular wave, which points towards severe congestion. So continuing with our patient, we have a severely congested patient, actually VExUS grade 3 severe congestion present. To summarize again, here you have the various grades. We have definitely 2 severely abnormal waveforms. We have the clinical findings of this patient. So this patient is severely congested. Once more, I want to emphasize that the kidney signal, the kidney venous signal, it's not easy to get. Here you have, for example, one arterial signal and here a little bit of a venous signal of the kidneys, which shows also 2 waves, but very often it's not an optimal signal. So keep in mind to find one signal you trust and measure it over and over again to get more experience, to really be used to what you are seeing. To summarize and to repeat here, all the signals for you to memorize and for you to also put in your ICU, put in your echo lab, to always make sure that you understand the signal and interpret volume status correctly. Additionally, I want to mention some more measurements of findings when it is enough water. When the coronary sinus is dilated, that is a hint to hypervolemia or also elevated pressures. A dilatation also over time of the right ventricle and the right atrium, a reduction in strain imaging in the follow-up is definitely pointing towards more and more volume overload, especially the size of the right ventricle. The no more changing of stroke volume and the LVOT points towards hypervolemia, so enough fluids. The raising filling pressures, the raising E to E prime, the E elevation, the E to A, which is then above 2, and many more signs from the evaluation of diastolic dysfunction. Of course, a patient who has edema, signs of heart failure, and the B lines. This is the pulmonary venous signal. You place a pulsed wave Doppler in the pulmonic vein. Also, if you have here a S signal and a D signal, and the S signal is smaller than the D signal, that also points towards elevated filling pressures, pointing towards, in this case, also hypervolemia. Elevation of left ventricular filling pressures and, of course, left atrial pressures. Here is no mitral stenosis present. Here you also see another wave, that's the so-called AR, so a flow reversal after the D wave, also indicative of elevation of filling pressures. There's some pitfalls. In this case, the coronary sinus dilatation was not due to hypervolemia. This is a persistent left superior vena cava. So you administer a milliliter of blood, half a milliliter of air, and 7 to 8 milliliters of a crystallid, for example. And if you administer it in the left arm, you see the flow coming from the persistent left superior vena cava. Take a close look over here and you see the bubbles entering, and this truly then is the proof that this is the persistent left superior vena cava and not pathological dilatation of the coronary sinus. So you need right heart contrast, blood, agitated saline, and a little bit of air, and a fast administration in the left arm. This is a multiplane view once more for you to see the severely dilatation of the coronary sinus and this nicely administered right heart contrast. The pulmonary venous signal is not always easy. You need good image quality, you need an optimal signal, and of course there are pitfalls like severe mitral regurgitation. There you also have this flow reversal in systole, indicative of either severe mitral regurgitation or elevation of filling pressures. And here you see the flow reversal due to this eccentric primary mitral regurgitation, which was then of course severe. You can also measure the IVRT of the right ventricle. It's a TDI S prime measurement, which you normally know, and you have the S prime and then you have the E prime and A prime of the right ventricle. And if you have a prolonged IVRT of the right ventricle, so the S prime and then the IVRT, the isovolumic relaxation time of the right ventricle, above 65 to 70 milliseconds, shows elevation of filling pressures or pulmonary hypertension as an additional measurement. But keep in mind, you have to use this measurement very often to feel secure and measure it correctly. These specific measurements and also these pathological findings you have with the tissue Doppler, you can take a look in the brand new video on diastolic dysfunction, which will be posted very soon, where we'll discuss also rarely used measurements to evaluate if there are elevated filling pressures of the left ventricle, the left atrium, or the right ventricle and the right atrium present. Here you have several signals, and you see here is a pathological IVRT, it's prolonged. Here it is normal, so there's almost no IVRT of the right ventricle seen. This is also a case of a normal IVRT with an optimized signal where you can nicely see that this is almost towards zero. So the E prime diastasis, A prime, the IVCT, the isovolumic contraction time. If you go to the signal, that's the isovolumic contraction time, the S prime, which is normal, and then basically no real IVRT of the right ventricle. Keep in mind the gallbladder wall. You can also scan if the gallbladder wall is thickened. That could be edema, that could be to ascites, in this case liver cirrhosis, but of course that also could be due to venous congestion because of heart disease. I also want to mention, because I truly love strain imaging, you can use left atrial and right atrial strain to differentiate if there are elevated filling pressures present. In this case, the LASR, the left atrial strain, the reservoir strain is only 3%, which is clearly an elevation of filling pressures. So you see the reduced left ventricular function, dilated right, dilated left ventricle, calcified valves, severely dilated atria. Here you have a pacemaker lead. So left atrial strain can help you to differentiate left atrial filling pressures. Right atrial strain can show you reduced right atrial filling pressures. Here you have a normal curve, ASR, so the right atrial strain, the reservoir phase. We have a conduit phase, which is this falling until the pre-A, so before the P wave, which is then the contraction, the RASCT. It's also the LASCT, the LAS conduit. the contraction phase and the conduit phase. Of course, here is atrial fibrillation present. You cannot measure. This is a normal signal with no pulmonary hypertension present, with no elevation of filling pressures present, in this case with normal right atrial function. An outtake I want to present you, there's a patient in the emergency department. The patient has elevation of BNP levels, so NT-proBNP is mildly elevated, and there's a large pleural effusion, and this has to be a patient for the ICU. This patient needs hemodynamic monitoring due to this huge pleural effusion. The pleural effusion was one-sided, so it was only on the left side, which is not per se a cardiologic cause where you think immediately about the heart. Here you see a complicated pleural effusion with a lot of strands inside. So this was a patient where the suspicion was that this is either cancerous or severe infection, for example, empyema. Overall, this patient was respiratory stable, and it turned out to be a carcinosis of the lung and also the diaphragm. Here you see a consolidation, a complicated pleural effusion. Here you see this multiple fibrinous strands, this complicated effusions. Here you cannot relieve the fluid properly. So this is a patient who primarily I wouldn't think about the heart as a cause of this complicated effusion. So if you see such an effusion, this is most likely inflammation or, on the other hand, a malignant disease. One patient I want to present you, it's Klaus, and everything is easy with Klaus. He received a Tendyne valve, so a relatively new valve where you see it's located over here. And this patient deteriorated after this scan, and we are going to answer why. So first of all, what is the Tendyne valve? This is another patient where you see the valve over here. These are the remnants of the mitral valve, the anterior, the posterior leaflet, and there's this huge umbrella-like structure and the actual valve inside here, and here the fixation at the cap, or with a cap at the apex, or more the apical regions. Here you see it in a transverse plane, the residual opening and closing of the mitral valve, which is of course not relevant anymore because there's this huge umbrella below. How does it look like in 3D? This is a TTE study. From top we see here the opening and this umbrella-like structure, and here we are looking from below towards the valve, and we see with this special light, the flexi light, this umbrella-like structure, and here the opening of the mitral valve. In a TE study you can even see it more clearly. Here is the valve. The valve is opening in this large umbrella. So here we have the umbrella-like structure, and this is the structure we will find at the apical region. So this is at the area of the atria, and here it goes to the ventricular side. So a minimal invasive valvular implanted structure. Now the suspicion was, is there a paravalvular leak? And take a close look over here. The LVOT seems rather narrow. Here you also have several turbulent flows, and looking at the subcostal imaging, you see that there's truly a turbulent flow, not towards the atrium, so it's not likely that there is a paravalvular leak, but that is actually LVOT obstruction. So the valve itself looks nice, but the LVOT is significantly narrowed. So LVOT obstruction leading to decompensation, and in his case, small amounts of crystalloids led to decompensation. With small dosages of diuretics, there was severe worsening of hemodynamics. A usage of catecholamines was catastrophic for this patient, and eventually, unfortunately, this patient did pass away. It's not always easy in our situation, and here I want to point out the severely dilated left atrial appendage, dilated left ventricle, severely dilated left atrium. In our situation, when a patient is deteriorating or deteriorated and needs an intensive care treatment, an intermediate care unit, or if there is a problematic situation in the emergency department, we use echocardiography. Echocardiography in the intermediate care unit in the ICU is our standard, also almost a standard echo. In the emergency department, it's more towards a point of care situation. Of course, in the intermediate care unit and the intensive care unit, it's still more focused, but we evaluate the left ventricle, the right ventricle, of course, diastolic dysfunction. We always take a look at the LVOT, the stroke volume. We look at the VTI and the pulse wave Doppler at the LVOT, the IVC, the SVC. So we already, when a patient is administered to our intermediate care unit or intensive care unit, we have the echo as our first hand standard. Then we use lung ultrasound. In this case, you see a pleural effusion and you see this small area which is a consolidation of the lung, but in this case it's small, but still it looks compressed. So it's in this case a telectasis, so no pneumonia and most likely no tumor, as the effusion is compressing this small structure. So the lung is also part of the exam. We look for effusions, consolidations, B-lines or commercial artifacts. So we look for fluid, free fluid, and we look for signs of infection. Then we use the liver veins, the portal vein, and the kidneys, because if a patient has acute kidney injury, we always take a look at the kidneys anyway. So all the structures are not that far away, and we use the VExUS exam also in our daily clinical routine. That is our easy approach, but of course, a very important point, and I mention it repeatedly, if it is still possible, then do the impossible and talk to your congested patient. In this case, a patient came to the emergency department. I was in the emergency department and the patient said, I'm dyspneic, I have edema, I'm sure I'm congested. It was a heart failure patient, and I did scan the IVC, it was dilated, and I did scan parts of the VExUS, and in this case, you see the signal of the liver veins and shows digestion. So the clinical status of the patient, the clinical findings, the history is very important. So if it is possible, if the patient is not intubated, talk to your patient and figure out with the clinical findings and your ultrasound if the patient in this case is congested or needs volume. So to summarize, our standard is the echo. We look for all findings needed to answer our clinical questions. The lung is part of the exam. We at least look for effusions and B-lines or comma-tails. So we also look, of course, where we see effusions for consolidations by telectasis. The liver veins, the portal vein, and the kidneys, they are not that far away. And if you're used to the VExUS exam, especially endlessly, so if you scan your patient from time to time, you get a better idea if the problem is congestion or if the patient really is hypovolemic. But again, it's not always easy, it's not always a straightforward answer. For the VExUS, Doppler measurements are known for years, especially in heart failure patients. Also the hepatic veins, as I mentioned before, in constrictive pericarditis, but also the portal venous system. It was published initially with heart failure patients. The evidence for VExUS is still limited but growing, and we combine the clinical findings and the VExUS and the other scans with ultrasound to figure out what actually the problem is. And keep in mind, not every patient has to have a VExUS grade 0. So sometimes a patient, in a heart failure patient, for example, can be a little bit congested, but not having severe problems because of the mild congestion. Breathing maneuvers can help. I don't like to do it in the VExUS exam because it changes also the intra-abdominal, and breathing maneuvers can help. So if you hold the breath for the VExUS exam, but very often it's not that easy with our patients. I tend to not use breathing maneuvers because most likely you will still get a good exam and then you do not have a change in pressures with respiration. That concludes the volume status and evaluation with ultrasound of the volume status.